Good afternoon, friends, and welcome to this special session on COVID webinars of management of children with COVID-19. And this is specially prepared for pediatric residents from already existing webinars. And before we start this thing, I request Dr. A.K. Devrari, our head of department, to say a few words about need for online learning now in changing scenario, along with that scope of these webinars for postgraduates. Dr. Devrari.
Thank you, Sushil and Rakesh Lodha and all the residents who have really worked hard for creating a resource material for all the resident doctors and the nurses who are taking care of COVID in children. We all know this is unusual time in which face-to-face interaction is going to be a problem. But we must appreciate the hard work which the resident doctors and nurses have done in COVID times in taking care of children who are sick with COVID infection or multi-system disease. I am also grateful to all the pediatrics resident doctors and the nurses that in addition to taking care of children and newborn babies in COVID facilities, they are also taking care of adults and geriatrics. By doing this, what they are learning is they are learning how to learn a good system in which teamwork is of utmost importance. In this series of webinar, which our department has created, you would learn about the testing methods, about COVID in children, about multi-system inflammatory syndrome, and what is the evidence at this point of time regarding even post-COVID care in healthcare facilities. I am very sure all of you are taking all precautions in terms of personal protection with PPE and also following biomedical waste disposal while you are posted into COVID areas and even non-COVID areas. Because as we pass through this pandemic time, it will take some time for us to be a little bit more confident so as to change our altogether behavior, which has to be made COVID appropriate while we are providing healthcare to our patients also. COVID in children is a little bit different with different challenges. And we know while the child is sick, he has to be taken care by one of the attendants. So how family has to get engaged into providing bedside care. And for that, we have to make sure that the person has to be COVID positive. Or if we don't have COVID positive family member, we have to have complete isolation for that child and also make sure all precautions are taken by the family member who is providing the care for that child. So as I said in the beginning, that this resource material which is created is global class material, which is contextualized to Indian situation. And it addresses the needs of our resident doctors and the nurses who are working in Southeast Asia region. And also we have to be very sure about the testing, what type of testing has to be done, why it has to be done, what investigation should be done in a child. And luckily in children, we know COVID is not very severe. It is only mild. or majority of the time it is asymptomatic. And we also know that very soon the schools are going to get opened. Children who are adolescent will have some mental issues or stress issues, which has to be dealt by all of us. And all of us who are sitting in the outpatient or seeing patient in the emergency department must have a very high index of suspicion of COVID infection in children with unusual clinical signs. So keep that in mind. And I'm very happy that all your questions and queries will be answered by the experts who have taken care of a lot of children who had COVID. And we have another set of children who get admitted in our COVID facilities. These are patients with comorbid conditions for which they are under chronic care, like oncology, rheumatology, pulmonology, nephrology. So we have to learn all that also. How do you take care and provide the normal care for those patients as per the standard guidelines? So all my best wishes to all of you who have joined, and many of you who are on YouTube. Feel free to ask questions to the experts, and it will be a learning which is going to be both sides learning for COVID in children. Thank you, Sushil, for asking me to address the students and the nurses. And I must put once again my heartfelt congratulations, or what you can say, thanks to all the resident doctors and nurses for taking care of all patients who are sick with COVID positive conditions who are getting admitted in trauma care facility. Thank you so much. Thank you.
Thank you very much, sir. Before we start the webinars, I would like to give you a background about these webinars. This was a part of for creating a resource material for taking care of children with COVID. And by 16 webinars, we try to cover all the aspects of care of children with COVID-19 infection. But that is a very big one, and all these are available on YouTube of AIMS SET facility. Here today, we have organized a special session for resident doctors. And these webinars were prepared by various experts across the country. And today, what we are going to discuss is diagnosis. What are the diagnostic tests? What is their status as of now? Then management of a mild illness, management of moderate, severe, and critical children in PICU. Then emerging disease, that is multisystem inflammatory disorder in children related to COVID-19. We have kept 2 webinars from that series, and that is to discuss the diagnostic criteria, pathogenesis, and then another is for the treatment. What is the status of various pharmacotherapy and other inflammatory drugs? So please write your questions, comments in chat box of YouTube or Zoom. We'll take question answer at the end of these 4 or 5 webinars. And those who have joined by Zoom link, please keep your mics mute. So now first we'll go to the first webinar, that is for the diagnosis of COVID-19 in children. So please continue to write your comments and questions.
I'm Dr. Sharan from the Department of Pediatrics, AIMS. Ever since being declared a pandemic in March 2020, COVID-19 has spread across the globe, affecting more than 213 countries and claiming over 7 lakh lives. Knowledge of its diagnostic tests are still evolving, and it is important that we have a clear understanding of the various tests available and their interpretation. Here is a brief outline of our presentation. We'll be touching upon the WHO case definitions, the latest testing guidelines by the ICMR, and the different samples used, and also we shall be briefly looking into each of the various testing methods available. The novel SARS coronavirus 2 is a RNA virus, and it is around 200 nanometer in size. It binds to the ACE2 receptors through the spike glycoprotein, which is central to its pathogenesis. The neutralizing antibodies seen as early as the first week after symptom onset, they are directed primarily against the S, that is the spike protein, and the N nucleoprotein. Incubation period, that is the time between exposure and the onset of symptoms for COVID-19, ranges from 2 to 14 days and an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person with fever and respiratory symptoms like cough, breathlessness, sore throat, etc., and a history of travel or residence in an area where there is ongoing transmission of COVID-19 14 days prior to the onset of symptoms. For example, any person residing in or with a history of travel to a hotspot or a containment zone develops symptoms within 14 days of return, then he or she is a suspect case. Similarly, if a patient develops symptoms within 14 days of having contact with a probable or a confirmed case, then he too should be called a suspect case. Also, if there is no other alternate explanation for the patient's respiratory illness, then he too will be grouped under a suspect case. In a setting of a pandemic, individuals fitting into these criteria are highly likely to be infected with the virus and have to be prioritized for early testing and isolated in a timely manner to prevent further spread. A probable case is one where a suspect case could not undergo testing for some reason or the testing was inconclusive. Confirmed case is one with confirmation of infection through nucleic acid detection. For its testing guidelines, ICMR prioritizes testing of patients with influenza-like illness, abbreviated as ILI. It is defined as presence of fever, that is temperature of more than 38 degrees centigrade, and respiratory symptoms like cough, breathlessness, and sore throat. ICMR recommends testing individuals who develop this influenza-like illness within 14 days of return from overseas, or in migrants developing ILI within 7 days of return from their hometowns. Also, hospitalized patients, frontline workers, and healthcare workers developing influenza-like illness have to be tested. Asymptomatic individuals who have contact with a confirmed case should be tested between 5 to 10 days after their last point of contact. This is keeping in mind the maximum viral load being present during the initial phases of illness and the average incubation period, which is 5 to 7 days. Hence, testing the individual between 5 to 10 days of exposure is likely to have a better yield. Severe acute respiratory illness, that is SARI, is defined as patients with fever and respiratory symptoms that warrant hospitalization. These patients need to be tested regardless of their history of exposure. Upper respiratory samples like the nasopharyngeal and throat swabs are most widely used for the diagnosis of COVID-19. Sample collection is an aerosol generating procedure and poses a potential risk to the healthcare workers and warrants donning with appropriate PPE. Saliva is emerging as a substitute specimen for virus detection. Data is still emerging, but it is said to be 90 to 95% sensitive in comparison with nasopharyngeal swabs. Rationale behind using saliva as a suitable specimen is: 1. Salivary glands are rich in ACE2 receptors and could potentially harbor the virus during the acute symptomatic phase. Secondly, sample collection is safe and cost-effective, and it does not require trained personnel donned in adequate PPE. Bronchoalveolar lavage is primarily used in intubated patients and is said to have a better yield than upper respiratory tract specimens. The serum is used for testing antibodies. It is useful to detect past infections and knowing the seroprevalence for epidemiological purposes. RT-PCR is the gold standard test for COVID-19. Let's briefly look into its steps. The virus is first deactivated from the sample by using lysis buffers, after which they are treated with a reverse transcriptase enzyme. So this reverse transcriptase enzyme generates a complementary DNA from the viral RNA. Next, we use primers and DNA polymerase, like the Taq polymerase, to identify specific viral nucleotides like the N gene, S gene, etc., and amplify them in logarithmic proportions. So the primer, which is synthesized in vitro, attaches to specific viral nucleotide sequences and activates them. The DNA polymerase further amplifies them. An activated Taq polymerase also triggers the Taqman probe to emit light, and the amount of light is directly proportional to the amount of viral particles in the specimen. This light can be measured by the RT-PCR machine. Since it is a novel virus and has a very high rate of mutation, more than one primers are used for a single RT-PCR test. Pooled RT-PCR tests a maximum of 25 specimens in a single session of RT-PCR. In this, samples from 25 different individuals are tested as a single sample through the RT-PCR. A negative result labels all the samples as negative, and in case of a positive result, the individual samples are tested separately. Pooled RT-PCR can be applied in scenarios where there is a very low pre-test probability, that is, while screening asymptomatic foreign returnees or migrants from green zones. This makes for better economical use of our limited testing resources. CBNAT works on principles similar to that of RT-PCR, and it is already well established in the diagnosis of tuberculosis. It involves an automated process where the sample is processed after being fed into the machine, and specific viral nucleotides are extracted by the machine, and it is further amplified similar to the RT-PCR technique. It is further detected by qualitative assays. Cepheid Expert Express SARS coronavirus 2 is been validated by multicentric trials and is found to have comparable sensitivity and specificity as the RT-PCR. It detects the N and the E gene and has a turnover time of about 45 minutes. The CBNAT, although more feasible than the RT-PCR, still requires a 24-hour air conditioning and an uninterrupted electrical power supply for its smooth functioning, which is not feasible in most of the peripheral health settings in India. It is used when results are required fast and patients are not symptomatic or mildly symptomatic and are going for urgent procedures like surgery or endoscopy. TrueNat is a mini version of the CBNAT or the Gene Expert, and it has a turnover time of approximately 1 to 1.5 hours. Being battery operated and portable, it can test up to 4 samples per batch. These features make it ideal for testing in peripheral healthcare centers, and it is found to have similar sensitivity and specificity to CBNAT. A negative TrueNat result does not require confirmation by a RT-PCR. Rapid antigen testing kits have bridged the gap for need of a point-of-care test that is reasonably sensitive and highly specific. It gives the result within 15 to 30 minutes of sample collection, and it has been validated by both the ICMR and AIMS and is found to have a sensitivity of 60 to 80% and a very high specificity of more than 99%. Current recommendation is to test all suspect cases with a rapid antigen test, and if positive, the results are interpreted as true positives. Negative results have to be reconfirmed by a repeat RT-PCR. After sample collection, the swab is drenched into a buffer solution where the viral particles, if present, are extracted. The solution is then dripped into a specimen well, and the card is read within 15 to 30 minutes of sample dropping. The assay detects the S protein of the virus, and which, if present, the specimen will give out a visible readout as shown here. Next, we come to the serological test detecting both IgM and IgG antibodies against the nucleocapsid or the spike protein of the coronavirus. These tests indirectly measure the host immune response and are particularly useful in children with mild or moderate illness who usually present late. IgG and IgM titers are found to appear at similar time points, that is after the first week of infection, and peak at around third week of infection. IgM titers have shown to decline subsequently, whereas IgG are said to last longer. Recent tests have shown that these antibody tests have a very high specificity of more than 99% and a sensitivity of 90% at the end of first week and 96% at the end of 2 weeks. Utility of serological tests is primarily to estimate the burden of the disease in the community and detecting past infection, especially in children who are usually asymptomatic and present late. A positive antibody test does not mean the person is immune to COVID-19. Currently, there is no evidence to suggest that seroconversion prevents further infection. Other non-specific lab parameters include lymphopenia, race, CRP, D-dimer, and ferritin, fibrinogen, and IL-6 levels. Additionally, multisystem inflammatory syndrome is characterized by elevated inflammatory markers along with raised creatine phosphokinase, troponin I, and dilated coronary arteries and reduced ejection fraction as seen in echo. Repeat testing prior to discharge is recommended only in severe cases, that is, patients with a respiratory rate of more than 30 or saturation of less than 90% on room air, or patients who developed ARDS or shock. Immunocompromised patients have shown to shed viruses for a prolonged period of time, and testing them negative prior to discharge is also being practiced. Studies have shown that the most common CT finding in children is the presence of ground glass opacities, subpleural in location, mainly involving the periphery and the posterior lungs. Image A shows a distinct ground glass opacity involving the posterior aspect of the right lung, which is well localized. Image B shows consolidation in the inferior lobe of the left lung surrounded by ground glass opacities. Image C is that of a child with severe disease showing diffuse consolidations and ground glass opacities in both lungs. To sum up our presentation, RT-PCR in an appropriately collected nasopharyngeal swab is the gold standard for diagnosis. CBNAT and TrueNat have been validated and do not need a confirmatory RT-PCR. Although not very sensitive, rapid antigen test is emerging as an ideal point of care for screening. A negative RT-PCR does not rule out COVID-19 infection, and as a single RT-PCR test has a sensitivity of around 80%. Antibody tests have no role in diagnosis of active infection. Thank you.
So now we have learned that when to suspect and how to confirm the diagnosis of COVID in children. Once we have made a diagnosis, then the next thing is how to manage it. So first thing would be to assess the severity. If it is a mild disease, then we can now, it can be managed at home. So now we'll learn how to manage a patient at home and how to train parents and when to ask them to bring the patient or to bring to the hospital and when to admit them for treatment of COVID. So now we'll go to the next webinar, that is management of a mild illness.
Good morning, everyone. I'm Dr. Amit Pathania, and today we'll be talking about management of mild symptomatic patient. We will be discussing about the case definition as per WHO, how do we assess severity of illness, and management of mild symptomatic cases. According to WHO case definition, they are classified into possible, probable, and confirmed case depending upon clinical, diagnostic imaging, lab, and epidemiological criteria. Clinical criteria: any person with at least one of the following symptoms: cough, fever, shortness of breath, or sudden onset of anosmia, aguesia, or dysgeusia. Diagnostic imaging criteria: radiological evidence showing lesions compatible with COVID-19. Lab criteria: detection of SARS-CoV-2 nucleic acid in a clinical specimen. Epidemiological criteria: at least one of the following two epidemiological links should be there: close contact with a confirmed COVID-19 case in the 14 days prior to onset of symptom, or having been a resident or a staff member in the 14 days prior to onset of symptom in a residential institution for vulnerable people where ongoing COVID-19 transmission has been confirmed. So, based on these, possible case is the one who meet the clinical criteria. Probable case is the one who any person meeting the clinical criteria with an epidemiological link or any person meeting the diagnostic imaging criteria. And the confirmed case is the one any person meeting the lab criteria, that is COVID positive. Symptoms of mild disease. Children may present with influenza-like illness, but they do not have respiratory difficulty in the form of rapid respiratory rates, chest indrawing, or hypoxia. Cutoff for rapid respiratory rates, fast breathing, are less than 2 months, it is 60 breaths per minute, 3 to 11 months, 50 breaths per minute, 12 to 16 months, it should be less than 40 breaths per minute, and more than 5 years or more than 60 months, it is 30 breaths per minute. There should be no lower chest indrawing. Oxygen saturation is more than 94% in room air. Some cases may have no fever or have only GI symptoms such as nausea, vomiting, abdominal pain, and diarrhea. Physical examination may show congestion of the pharynx, but no auscultatory abnormalities. In mild cases, child is usually cared at home, but sometimes admitted in COVID care facility. Thorough education of parent, caregiver need to be done if the child is cared at home, which we will learn in subsequent slides. There is no established therapy as of now, so supportive care is the mainstay. Infection prevention and control measures should be followed at all steps for all suspected and confirmed cases. The child with mild COVID symptoms can be taken care either at home or COVID care center. The doctor should assess the feasibility that a child can be cared at home. The child should fulfill the following criteria: mild disease as assessed by doctor, have the requisite facility at their residence for self-isolation and also for quarantining the family contacts. A caregiver should be available to provide care on 24/7 basis. a communication link between the caregiver and hospital. They should download country-specific tracking app, like for India, it is Arogya Setu app. Attendant agree to monitor the child and regularly inform child health status to the district surveillance officer or doctor. And parents or attendants agree to fill in an undertaking on self-isolation. The aim is to keep the high-risk patient under medical supervision. All the medical and social issues should be taken into consideration before sending the child to home quarantine. In the event that the child tests positive for COVID-19, she may be eligible for home isolation only if the response to 1ABC or and 2A to E are all yes. So one is eligibility criteria for home isolation. A is respiratory rate should be less than a specific cutoff. Room air saturation more than 94%, and there should be absence of all of the following high-risk features, that is infants, cardiovascular disease, including hypertension, diabetes, immunocompromised states, chronic lung, kidney, liver disease, cerebrovascular disease, or if the child is obese. Second is social eligibility criteria for home isolation. So all should be there. That is, 2A is the patient has a requisite facility for isolation at his/her residence and also for quarantining the family contacts. Caregiver is available to provide care on a 24/7 basis. Country-specific app should be downloaded on mobile. Like for India, it is Arogya Setu app. And it should remain active at all times through Bluetooth or Wi-Fi. The patient has agreed to monitor his/her health and regularly inform his/her health status to the home isolation. Patient has filled an undertaking on self-isolation and shall follow home isolation quarantine guidelines. Child should be cared in COVID care facility if home isolation is not feasible. That is small house, overcrowding at home, high-risk patients staying at home, and inadequate facility. Regular monitoring not possible due to any reason, or if the child has high-risk factors, that is immunosuppressed, chronic diseases, they should be admitted in hospital for monitoring and care. All children at home isolations or COVID care facilities or hospital should be cared in a child-friendly environment, and parent or attendant may be allowed to take care with proper PPE kits and precautions. Treatment is mainly symptomatic. Like for fever, we can give paracetamol at the doses of 10 to 15 mg per kg per dose and may be repeated whenever required. NSAID should be avoided, although there is no evidence against these as of now, but they should not be used. There is no role of cough suppressants. If throat irritation is there, then warm saline gargling may be done thrice a day. Honey is a throat soother. At present, antibiotics are not indicated. Emphasis should be given on proper nutrition. Citrus fruit should be taken. Junk, spicy, and fried food should be avoided. Plenty of warm fluid should be taken. Hydration should be maintained at all times. Rest and deep breathing exercise should be done, especially pranayams. Room temperature should be ambient. Though there is a lot of literature on various medication having benefit in COVID treatment, but as of now, no single drug cures the disease. I repeat, no single drug cures the disease. Various drug studies are chloroquine, hydroxychloroquine, ivermectin, antiviral agents like lopinavir, ritonavir, remdesivir, favipiravir, or immunomodulator including tocilizumab, interferon beta, or plasma infusion. Parents or caregivers should be trained to monitor child at home by explaining how to count respiratory rate. They should do at least twice a day and when child is not crying. They should be explained how to look for chest indrawing, nasal flare, to look for bluish discoloration of body, to look for cold extremities, and to monitor urine output. They should use oxygen saturation monitoring by handheld pulse oximeter. They should keep monitoring chart and communicate to doctor, and they should know where to go in case of emergency. Danger signs should be explained. Parents should seek help when child develops breathing difficulty, rapid respiratory rate, chest indrawing, nasal flare, bluish discoloration, reduced activity, lethargy, poor feeding, altered sensorium, seizure, or hypoxia, monitored as SpO2 less than 94%. If sent to home, parent or caregiver should maintain a monitoring chart as shown, or some simpler format can be used. And when the child is in COVID care facility, they should be monitoring by doctors or trained nurse at least twice a day for vitals, heart rate, respiratory rate, temperature, oxygen saturation, development of chest indrawing, intake output, especially reduce or difficulty in feeding or reduce urine output. They should look for lethargy, seizures, and general activity of the child. Child should be transferred to hospital if there is respiratory distress, SpO2 less than 94% on room air, shock or poor perfusion, poor oral intake, especially in infants and young children, lethargy, especially in infants and young children, or if there is seizures or encephalopathy. Now we will discuss some frequently asked questions. The question is, how many days to isolate the child? And the answer is, to keep child isolated for at least 10 days of symptoms onset and at least 3 days of afebrile period. Further home isolation for next 7 days with health monitoring at home is also recommended. For example, if a patient with symptoms for 14 days, the child can be discharged for next 3 asymptomatic days, that is 14 days plus 3 days is equal to 17 after the date of onset of symptoms. Whether to do repeat tests for COVID, the answer is, if no high risk factors, there is no need to repeat tests to document recovery. What is the risk of transmission of illness from child to other family members? As there may be some risk of transmission, precaution including mask, physical distancing, hand hygiene, isolation should be maintained. Does the child need vaccination after infection? The answer is, as of now, vaccines are not available. It's unclear whether infection provides lifelong immunity or child will be at risk of repeated infection. Will the child have long-term complications? As this is a new condition, long-term complications are difficult to predict. With more studies, guidelines may be developed. When can child be sent to school or play with other children? The answer is, after 14 days of onset of symptom, child become non-infectious, can be sent to school or playing group, provided at both places physical distancing norms are followed if the schools have been allowed to open up. So to summarize, majority of children with COVID infection have mild illness characterized by cold, cough, but no difficulty in respiration, that is respiratory rate less than a specific cutoff. Moderate cases may mimic non-severe pneumonia. These patients can be managed at home with home isolation after assessment. And there is no evidence to suggest beneficial role of antiviral, hydroxychloroquine, tocilizumab, or plasma infusion. Thank you.
So now we have learned about how to identify mild illness and how to manage them. So now we'll learn about moderate, severe and critical patients, how to manage in hospital and in pediatric intensive care unit. Please write your questions, comments in a chat box. So now we go on to the next webinar, that is on moderate, severe and critical children.
In this session, I will be discussing about the management of children with COVID-19 having moderate to severe illness. This presentation will be covering the following aspects: case definitions of moderate and severe COVID illness, indications for hospital and PICU admission, general principles of management as recommended by WHO, how to initiate and monitor oxygen therapy, high flow nasal cannula and non-invasive ventilation, case definitions of critical illness, how and when to initiate invasive ventilation, explaining the procedure of intubation and general care of ventilated children, followed by management of shock, and lastly supportive measures and prevention of complication in critically ill children. As per WHO, children with following features categorized into moderate illness. First is the clinical signs of pneumonia, that is fever, cough, fast breathing and mild chest retraction. Children with no signs of severe pneumonia and saturation must be more than 90% on room air. Fast breathing, that is defined by less than 2 months more than 60 per minute, 2 to 11 months more than 50 per minute and 1 to 5 years more than 40 per minute. Children with clinical signs of pneumonia, that is cough or difficulty in breathing, plus at least one of the following, that is central cyanosis or saturation less than 90% on room air, severe respiratory distress, example fast breathing, grunting, very severe chest indrawing, and general danger signs, inability to breastfeed or drink, lethargy or unconsciousness or convulsions. Fast breathing, that is as defined earlier, are classified into having a severe illness. So hospital admission is considered in children with COVID-19 if any one of the following criteria met: presence of respiratory distress or saturation is less than 92% on room air, presence of shock, poor peripheral perfusion, general danger signs, inability to feed or drink, lethargy or unconsciousness, seizures or encephalopathy. Children with high risk for severe disease with milder symptoms such as congenital or acquired heart diseases, chronic lung, liver, kidney or neurological diseases, or on immunosuppressive drugs, congenital or acquired immunodeficiency, those children also needs to be hospitalized. Admission into the intensive care unit should be considered in children with moderate to severe ARDS requiring mechanical ventilation, shock requiring vasopressor support, worsening mental status, or having multi-organ dysfunction syndrome. The general principles in the management of children with COVID-19 are as follows. WHO recommends COVID-19 care pathway at all levels should be developed and followed. Infection prevention and control measures should be adhered for all suspected as well as confirmed cases. Endemic infections such as dengue and malaria are to be ruled out as per the clinical setting. Supportive care consisting of ensuring adequate nutrition, hydration and rest. Symptomatic treatment with paracetamol for fever, which is given 10 to 15 mg per kg per dose as and when required, or every 4 to 6 hourly if required. Ibuprofen and other NSAIDs are to be avoided. Children with moderate disease are admitted in isolation to contain the virus transmission. The admission facility may be dedicated COVID health center or district hospital or medical college hospitals. Hematology and biochemistry laboratory testing, electrocardiogram and chest imaging should be performed at admission in order to monitor complication as well as monitor organ function. Oxygen supplementation is given to maintain saturation more than 92%. If inhaled bronchodilators are required, then MDA with spacer is preferred over nebulization to reduce aerosolization. Empirical antimicrobials are not recommended in moderate disease unless there is strong clinical suspicion of a bacterial infection, and it may be considered as per local antibiogram and guidelines in immunocompromised children and children who are under less than 5 years of age. IV methylprednisolone, which is given at a dose of 0.5 to 1 milligram per kg, or dexamethasone, which is given at 0.1 to 0.2 milligram per kg for 3 days, may be considered in children in whom oxygen requirement is increasing within 48 hours and inflammatory markers are increasing. All the children with COVID-19 infection monitored with vitals, heart rate, blood pressure, oxygen saturation, work of breathing and oxygen requirement of children with moderate COVID-19 for the signs or symptoms of disease progression. Laboratory-wise complete blood count with differential count, absolute lymphocyte count, kidney function and liver function test are to be done daily, and CRP, D-dimers, ferritin are monitored every 48 to 72 hours if the resources are available. Monitor for increased work of breathing, hemodynamic instability, increase in oxygen requirement. If any of the above occurs, consider shifting to a dedicated COVID hospital with tertiary care setup. As of now, there are no established therapies for COVID-19, and also there is no evidence of benefits of giving following drugs to moderately affected children. These are chloroquine and hydroxychloroquine, ivermectin, antiviral agents like lopinavir-ritonavir combination, remdesivir, humifenovir, favipiravir, and immunomodulators such as tocilizumab, interferon beta, and as well as plasma infusion. Supplemental oxygen therapy should be given to children with severe acute respiratory illness and with respiratory distress, hypoxemia or shock. The target saturation is more than 94% during resuscitation and 90% for children who are recovering and stable. Nasal prongs or cannula are preferred in children as it might be better tolerated. A surgical mask or hood covered to decrease the risk of aerosolization and droplet spread. If the child is on oxygen through prongs and saturation is less than 90% with minimal respiratory distress, the options in the next level are either a face mask at flow of more than 5 liters per minute providing FiO2 of 40 to 60%, or oxygen hood at flow of more than 5 liters per minute providing FiO2 of 30 to 90%. Or we can use Venturi mask which can provide FiO2 28 to 60%, or non-rebreathing mask at a flow of 10 to 15 liters per minute providing FiO2 up to 90%. These devices can be tried before escalating the respiratory support to the high frequency nasal cannula or non-invasive ventilation. Now we go to the management of severe illness. So children with severe disease may be cared in a center equipped with pulse oximeter, functioning oxygen systems and disposables, single-use oxygen delivering interfaces, that is nasal cannula, Venturi mask, non-rebreathing mask with reservoir bag. Children with severe pneumonia and danger signs should receive emergency airway management and oxygen therapy during resuscitation to target a saturation of more than 94%, and the same target saturation is more than 90% in a stable child. Empirical antimicrobials should be given within 1 hour of admission whenever bacterial infection is suspected after sending blood culture, and it is based on clinical judgment, patient host factors as well as the local epidemiology. Investigations, complete blood count with differential and biochemistry laboratory testing, electrocardiogram and chest imaging should be performed at admission in order to monitor complications and organ function. Close monitoring of children, vitals, heart rate, respiratory rate, blood pressure, saturation, work of breathing, oxygen requirement should be done for signs of symptoms of disease progression. Complete blood count with differential count, absolute lymphocyte count, renal and liver functions are to be done daily, and CRP, D-dimer, ferritin are monitored every 48 to 72 hours if resources are available. Bubble nasal CPAP may be used with airborne precautions in newborn and children with severe hypoxemia when resources for invasive ventilation are not available. Now we see when and how high flow nasal cannula is used. This heated humidified high flow nasal cannula may be used preferably over CPAP or BiPAP system if the target saturation is not achieved with oxygen delivery devices, which have been mentioned above. Switch on the machine only after fixing the nasal cannula. Start at 5 to 1 liter per kg per minute and increase up to 2 liter per kg per minute of flow if required. Use minimal flow that makes the baby comfortable and target saturation is 90 to 94%. Monitor heart rate, respiratory rate, saturation and work of breathing. If no response in 1 to 2 hours, then escalation of respiratory support is required. Consider providing a 3-ply mask to cover the mouth and nose of the child while receiving high-flow nasal cannula therapy to reduce the spread of aerosol. Coming to the non-invasive ventilatory support, it is offered only in selected children with respiratory distress as the failure rate is very high. Use conventional ventilators for non-invasive ventilation with a non-vented oronasal mask or helmet, or as non-invasive ventilator with single limb and vented mask have high risk of aerosolization. Connect a bacterial or viral filter at the exhalation port and use the lowest possible PEEP to achieve the target saturations. Monitor closely and intubate if the patient deteriorates or there is no improvement in 1 hour. Coming to the severe illness, children with COVID-19 infection having any one of the following classified as critically ill: acute respiratory distress syndrome as defined by the pediatrics ARDS guidelines from the Pediatric Acute Lung Injury Consensus Conference, sepsis who has suspected or proven infection and greater than 2 age-based SIRS criteria, or septic shock as manifested by hypotension or any 2 or 3 of the following. Those are altered mental status, bradycardia or tachycardia, prolonged capillary refill or weak pulse, mottled or cool skin, petechial or purpuric rash, high lactate, reduced urine output, hyperthermia or hypothermia. Now coming to the management of child with ARDS. Children with COVID-19 and mild ARDS, a trial of high flow nasal oxygen therapy or non-invasive ventilation like CPAP or BiPAP may be used with strict adherence to the airborne precautions. High flow nasal oxygen therapy or non-invasive ventilation are to be avoided in children with hypoxemic respiratory failure and hemodynamic instability or multi-organ failure or abnormal mental status. Children receiving a trial of high flow nasal oxygen therapy or non-invasive ventilation should be cared for and monitored by person who are experienced with high flow nasal oxygen therapy and NIV and capable of performing endotracheal intubation in case of deterioration or non-improvement, that is after the trial of 1 hour. In children with COVID-19 who are critically ill, intubation is considered if any one of the following conditions present: severe respiratory distress, that is not able to maintain saturation more than 90% on non-invasive oxygen supplementation, when PaO2 by FiO2 ratio is less than 200 or PaO2 by FiO2 is less than 300 with hypotension requiring vasopressor support, or having a Glasgow coma scale of less than 8 with threatened airway. Intubation in COVID-19 children done with all airborne precautions and the following steps are adhered strictly. The most skilled member of the team should be identified at the beginning of each shift for performing intubations. Pre-oxygenation with 100% FiO2 with non-rebreathing mask or nasal prongs. Bag and mask ventilation is avoided due to risk of aerosol generation. If needed, it can be given by connecting a viral filter. If readily available, intubation should be performed using a video laryngoscope. Cuffed endotracheal tubes should be used to avoid peritubal leak and dissemination of aerosols. So rapid sequence intubation should be done, and during induction monitor for hemodynamic instability and use fluids and vasopressors if required. X-ray chest is ordered to confirm the position of the tube. After intubation, appropriate cleaning and disinfection of the equipment and environment should be done. The following are the general ventilatory strategies recommended in managing the intubated children with COVID-19. Target a lower plateau pressure, that is less than 28 cm of water, and a lower pH is permitted, that is 7.15 to 7.30. Tidal volumes 3 to 6 ml per kg of predicted body weight in case of respiratory system with poor compliance, and 5 to 8 ml per kg of predicted body weight with preserved compliance. In children with moderate or severe ARDS, a trial of higher positive end expiratory pressure is given instead of lower PEEP, and it is to be individualized. Application of prone ventilation when PaO to FiO2 ratio is less than 150 or oxygenation index is more than or equal to 12 or oxygenation saturation index is more than 10 is preferably done for 16 hours per day. That may be considered for pediatric patients with severe ARDS where sufficient human resources and expertise are available. Referral of children who have refractory hypoxemia, example PaO to FiO2 ratio less than 50 for more than 3 hours or PaO to FiO2 of less than 80 for more than 6 hours despite lung productive ventilation for extracorporeal life support. The general care of the ventilated patient children includes always use fresh, preferably disposable ventilator circuit for every new patient. Use viral filter in the expiratory limb of the circuit. Heat and moisture exchanger to be changed every 48 hours or when visibly soiled. Avoid disconnection of the circuit which causes loss of PEEP, atelectasis, increased risk of infection of the healthcare workers. Use closed suctioning technique and avoid routine suctioning to reduce the aerosol generation. Appropriate sedation should be ensured and intermittent muscle relaxants may be used, although continuous infusion of neuromuscular blockers are not routinely recommended. Conservative fluid management strategy must be followed for ARDS patients without tissue hypoperfusion and fluid responsiveness. The management of sepsis and septic shock includes standard care consisting of early reorganization and the following treatment, which are done immediately within 1 hour of reorganization. Initiation of fluid bolus, antimicrobial therapy, vasopressors for hypotension, and central venous and arterial catheters should be based on the resources availability and individual patient needs. During resuscitation for septic shock in children, give 10 to 20 ml per kg of crystalloid fluid up to 60 ml per kg, either normal saline or Ringer's lactate, as a bolus in the first 30 to 60 minutes. Hypotonic solutions and colloids are to be avoided. If there is no response to fluid loading or signs of volume overload appear, then one has to either reduce or discontinue the fluid administration. During resuscitation, consider using dynamic indices of volume responsiveness such as passive leg raising, fluid challenges with serial stroke volume measurements, or variation in systolic pressure, pulse pressure, inferior vena cava size, or stroke volume in responses to the changes in the intrathoracic pressures during mechanical ventilation to guide the volume administration. If signs of fluid overload are apparent or the shock persists after 2 fluid bolus, start vasopressors. If the central venous catheters are not available, vasopressors can be given through the large peripheral vein and closely monitor for signs of extravasation, local tissue necrosis. If extravasation occurs, stop infusion, and vasopressors can also be given through intraosseous needle. In children, epinephrine is considered as first-line treatment, while norepinephrine can be added if the shock persists despite optimal dose of epinephrine. If signs of poor perfusion and cardiac dysfunction persist despite achieving MAP target with fluids and vasopressors, then consider starting an inotrope such as dobutamine. The supportive care of the critically ill child with COVID-19 infection includes the following measures. Head and elevation. It may be avoided if child has poor perfusion or shock. Oral hygiene with antiseptic mouthwash twice daily. Early enteral nutrition starting within 24 to 48 hours of admission. Glycemic control to maintain blood glucose in the range of 100 to 180 mg per deciliter. Insertion of Foley's catheter for accurate urine output monitoring. Insertion of appropriate size feeding or Ryle's tube for enteral feeding as well as medications. Care of central venous catheter to prevent catheter-related bloodstream infection. Position change every 2 hours to prevent blood sore. The following measures are followed to prevent complications in the critically ill children. Daily assessment for readiness of extubation and sedation window to be given to reduce the number of days of mechanical ventilation. Head and elevation, close suctioning, changing the circuit if it is soiled, changing heat mask exchanger when malfunctioned, when soiled, or every 5 to 7 days to reduce the incidence of ventilator associated pneumonia. Anticoagulant prophylaxis with low molecular weight heparin or heparin to prevent deep vein thrombosis. Sterile insertion techniques must be followed while placing the central catheter, and removal of central venous catheters considered if no longer is required in order to reduce the catheter related bloodstream infections. Positioning every second hourly to prevent bed sores, yearly enteral nutrition preferably within 24 to 48 hours of admission, and administration of H2 blockers or proton pump inhibitors in patients with risk factors for GI bleeding to reduce the ulcers as well as bleeding. The risk factors include mechanical ventilation more than 48 hours, coagulopathy, renal replacement therapy, liver disease, multiple comorbidities, and higher organ failure score. Actively mobilize yearly in the course of the illness as soon as the child is stable to prevent the ICU related weakness. Summarizing, children should be categorized based on signs and symptoms and management protocol to be followed according to the severity of illness. Infection prevention and control measures should be followed for all suspected and confirmed cases. Oxygen therapy, high flow nasal cannula are the tools for respiratory support in children with moderate illness, non-invasive ventilation and invasive ventilation for ARDS. And airborne precautions have to be followed in all cases. Low tidal volume, low PEEP plat, moderate to higher PEEP, permissive hypercapnia and prone ventilation are the main ventilatory strategies. Antimicrobials are administered only if bacterial infection is suspected or in children with sepsis and septic shock. Close clinical monitoring of vitals, heart rate, respiratory rate, blood pressure, saturation, work of breathing, and oxygen requirement in any category is paramount clinical importance in the management of COVID-19. Antivirals like remdesivir, tocilizumab, and plasma therapy are to be used only in clinical trial settings. Thank you.
Okay, so now we have learned about diagnosis and management of various severity of COVID infection in children. Before we go on to the multisystem inflammatory syndrome in children, we have some questions. We'll finish that, and then next two webinars will be on multisystem inflammatory disorder. So the first question I'll ask Dr. Nitin, who is working with us. He is a DM in pediatric pulmonology and intensive care. First question is, should antiviral be given in mild to moderate disease in children?
So as already discussed in the second seminar and third seminar, so antivirals are not currently recommended for mild to moderate disease. The care of the children is supportive care with the constant watch for worsening for mild and moderate disease. And as of now, antivirals are not very well established. The role is not very well established in children as of now.
So it's clear that no role of any antiviral, irrespective of the severity of disease. And it is also recommended by WHO that no role of even remdesivir. The next question is there any prophylaxis recommended for children if adult member is suffering from coronavirus infection?
So again, for any age group, prophylaxis as of now is not recommended for coronavirus, COVID, if there is contact with the COVID positive patient. And children as such have milder illness compared to adults. So it is probably going to have a milder illness, and no known therapy is currently recommended or established for prophylaxis against COVID-19.
So to re-emphasize, we do not have any medication for prophylaxis of coronavirus infection, including no role of any vitamin C, zinc, or tetracycline, ivermectin, or remdesivir. So now the third question is the disease severity classification only dependent on respiratory symptoms? What about a child who has isolated gastrointestinal symptoms or severe dehydration or other extrapulmonary manifestations?
So again, to begin with, it was a severe respiratory illness, and the classifications were derived from what was the classification for pneumonia. But there is also classification like critically ill or critically sick children. So children who have extrapulmonary manifestation, but they have severe disease, the indication for therapy and hospitalization should be addressed by the severity of illness. So if somebody is having severe diarrhea, that patient should be managed inpatient and with the appropriate therapy for diarrhea. And some patient coming with the mild diarrhea, that patient can be managed on ambulatory care.
Okay, so depending on severity, now we are seeing more and more extrapulmonary manifestations. So depending on the severity, you can classify and decide about admissions. Now there is another question. Do we investigate for inflammatory markers routinely in moderate disease? So it is not required in all moderate disease. It is a clinical monitoring. If child is improving, probably you will not do any investigation, including X-ray or CT scan, if it is a moderate disease, provided that the patient is improving. But not improving or worsening, then definitely you may be able to identify them with appropriate inflammatory markers as well as imaging. So if a child is admitted in a hospital where facilities exist and patient is worsening, a child is worsening, in that case, you can go for it. Otherwise, it's not required. So other is how long should steroids be given if needed? So one is steroids are indicated only if you are suspecting it to be a cytokine storm in a severe and critically ill child, and you will give it for 5 days in the beginning, full doses, and depending on the clinical response and inflammatory markers, you can taper over next 2 weeks, and if required, even you can give it longer, depending on the severity and inflammatory markers. Then there is a question regarding why adrenaline is preferred over noradrenaline as it is a septic shock. Dr. Nitin.
So just like the guidelines for shock in management of COVID, they are based on or derived from the septic shock guidelines mostly. But more and more we are seeing that these children are likely to have cardiac dysfunction. So we should be careful that for septic shock, the first line therapy for children is adrenaline and not noradrenaline, especially if there is no features of warm shock. And so even for COVID, the first line therapy as of now recommended is adrenaline, and we should be titrating it, and we should be deciding about the therapy depending upon what kind of shock the patient is presenting. If there is good cardiac function and there are features of warm shock, you might start noradrenaline. But most of the times there is cardiac dysfunction and there is cold shock. So it's good to, it will be like preferred choice should be adrenaline in such a patient.
Okay, so till now we had discussed that once the child is infected, how to manage either at home or in a COVID care center or in a COVID hospital. But now we'll go on to discuss a newly emerging illness specific for children, that is a multisystem inflammatory syndrome of children related to COVID, and that may be seen in your clinical practice in your OPD as well as in your ward, admitted even in the non-COVID ward. So we need to be aware about this condition. We are learning more and more about it as the time passing. And this is important. Again, I say that these children will be admitted in your ward, in your, even if it is a non-COVID facility. And it happens after the viral infection has already happened, say 3 to 6 weeks or more. So now when the Delhi has reached to a peak, third peak, and now we expect that a lot of children are going to come to you of a various severity of multi-system inflammatory syndrome. So first we'll have a first webinar on what is the pathogenesis, how to make a diagnosis, what are the clinical features, and then the second will be how to manage them by various modalities.
Now we shall discuss the spectrum of multi-system inflammatory syndrome in children temporally related to COVID-19. We will discuss the epidemiology, pathogenesis, clinical features, and the differential diagnosis, and finally sketch a diagnostic algorithm for multi-system inflammatory syndrome. As we learnt in the early days of COVID-19 pandemic, children were noted to have a relatively mild disease compared to adults. However, amidst April 2020, there was an eruption of some severe cases in children with an epidemiological link to COVID-19, following which NHS England issued a warning against such cases. This entity was defined as multi-system inflammatory syndrome in children and adolescents temporally related to COVID-19 by WHO, multi-system inflammatory syndrome in children by CDC, and pediatric multi-system inflammatory syndrome temporally associated with COVID-19 by RCPCH. As on July 31st, 2020, over 700 cases have been reported from the world, with a majority of these from USA and Europe, but reports from Asia have also started erupting. From the reported cases, it is clear that this disease predominantly affects previously normal children with evidence of current or past COVID infection and has prominent gastrointestinal and cardiac manifestations. WHO case definition for multi-system inflammatory syndrome in children and adolescents temporally related to COVID-19 requires all 6 of the following criteria to be fulfilled: age up to 19 years, presence of fever for at least 3 days, clinical signs suggestive of multi-system involvement, with presence of at least 2 of the following 5 features: rash, bilateral non-purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, cardiac involvement in the form of cardiac dysfunction, pericarditis, valvulitis, or coronary abnormalities on echocardiography or elevated cardiac biomarkers, evidence of coagulopathy in the form of deranged PT, PTT, or D-dimer, and acute gastrointestinal symptoms such as vomiting, diarrhea, or abdominal pain. Additionally, there must be elevated inflammatory markers like ESR, CRP, or procalcitonin, with no other obvious microbial cause of inflammation, and there must be an evidence of SARS-CoV-2 infection in the form of positive RT-PCR, antibody test, antigen test, or even a contact with a positive case. The CDC criteria is similar, but has some subtle differences compared to the WHO criteria, such as it includes age up to 21 years, it defines exposure to a contact to have been occurred 4 weeks prior to the presentation, and it has a mandatory criteria that the disease must be a severe illness requiring hospitalization. Here we have mentioned a few of the published reports on multi-system inflammatory syndrome. What is noticeable is that this data is the frequent involvement of gastrointestinal and cardiac systems as highlighted previously, with many patients also having mucocutaneous involvement akin to Kawasaki disease. Around 2/3 of the patient test negative for RT-PCR for COVID, but 50 to 90% demonstrate a positive antibody test. Because of the multi-system involvement, these children need close monitoring and may require intensive care support. Immunosuppressants and immunomodulators are the mainstay of treatment. Intravenous immunoglobulin and steroids are most commonly used. the overall mortality is less than 5%. Looking at the epidemiological data related to COVID-19 from March to May 2020 from USA, we see that the peak of COVID-19 test positivity rate was reached in April 2020, but the number of reported cases of MISC started rising later. There was a gap of around 3 to 6 weeks between the peak of COVID-19 infection and a noticeable surge in MISC cases. Similar findings were reported from Europe. As on 3rd June 2020, only 2 cases of MISC were published from India. However, there are several more unpublished cases to our knowledge. These studies had a similar presentation and outcomes as the ones reported from the West. But considering the delayed peak of COVID-19 in India, a surge in cases of MISC may be seen from India, especially as clinicians become more familiar with the presentation of the disease and more cases are picked up. Coming to the pathogenesis of MISC, several aspects are unclear and are still evolving. What is relatively more certain is that the terminal point of the pathogenesis is cytokine storm. Yet poorly understood, the postulated mechanisms include the following. The most widely accepted theory is that after a SARS-CoV-2 infection, there is a formation of antibodies against the virus by the body, followed by clearance of the virus from the system. Subsequently, there is an IgG-mediated enhancement of the immune response, leading to a hyperimmune response, causing a cytokine storm. This in turn causes the characteristic multi-system involvement. This hypothesis is supported by the observation that most patients test negative by RT-PCR for COVID but have a positive antibody test. In addition, the lag of 3 to 6 weeks between the peak of COVID infection and the peak of MISC cases further compound this hypothesis. The second hypothesis predicts that after a COVID-19 infection with a heavy viral load, there is blockade of the interferon responses, as has been seen with other coronaviruses. Subsequently, there is a delayed response to the active infection in the form of an exaggerated cytokine surge causing MISC. The third hypothesis states that instead of directly leading to a cytokine storm, SARS-CoV-2 may be acting as an intermediate primer or a co-stimulatory agent, or just providing a portal of entry to an as yet unknown trigger which is causing the immune response and causing MISC. Why this phenomena is occurring predominantly in children and why certain systems are more commonly affected is not definitively known. Coming to the clinical features, fever is a universal symptom and is a necessary criteria for diagnosis of MISC. Gastrointestinal symptoms have been reported in 60 to 100% of the published cases and include abdominal pain, vomiting, and diarrhea. Patients have even presented with an acute abdomen requiring exploratory laparotomy in a few cases. Cardiac involvement, especially as left ventricular dysfunction, is seen in over 50% of the cases. Similarly, shock is a commonly seen feature, seen in 50 to 80% of the cases, and in most series has been seen to be clinically warm type of shock. MISC has several features which may mimic those seen in Kawasaki disease. In fact, the criteria for Kawasaki disease may be met in around 40% of the cases. These features include rash, which is usually polymorphous and may be seen on the trunk or extremities. Similarly, these children may have bilateral non-purulent conjunctivitis, mucous membrane involvement in the form of mucosal erythema and strawberry tongue, and swelling over hands and feet. In addition, coronary artery abnormalities have been reported in 8 to 48% of the patients, but long-term data about the progression of these abnormalities is not known. This image shows the typical erythematous maculopapular rash seen on the extremities and trunk. Targetoid rashes have also been described. Other clinical features include neurocognitive symptoms, which can manifest as headache, lethargy, confusion, or irritability in a younger child. As opposed to COVID-19 infection in adults, respiratory symptoms are usually not a prominent symptom of MISC and may be seen in 20 to 60% cases. Serositis in the form of pericarditis and pericardial effusion, pleural effusion, and ascites may be seen in a minority of patients. In many cases, patients may develop multi-organ dysfunction in the form of respiratory failure, acute renal failure, and less commonly, acute liver failure. Let us now discuss a few differential diagnoses that may mimic MISC. Kawasaki disease is a close differential with several overlapping features. However, some differences have been noted between the two conditions. In MISC, the children are typically older, usually 8 to 10 years of age, while Kawasaki disease is mainly seen in children below 5 years of age. Gastrointestinal symptoms, myocardial dysfunction, and shock are much more common in MISC. Inflammatory markers have been seen to be much highly elevated in MISC as compared to Kawasaki disease. And thrombocytopenia is a relatively common feature of MISC but is rare in Kawasaki disease. Toxic shock syndrome is another close differential because of the presence of multi-organ involvement along with fever. However, a microbiological evidence of Staphylococcus or Streptococcus is necessary for the diagnosis of TSS. Bacterial sepsis and septic shock cannot be ruled out in most severe cases of MISC at presentation and needs workup. However, certain features like coronary artery abnormalities are not seen in sepsis. Lastly, in endemic countries like India, dengue and dengue-related secondary hemophagocytic lymphohistiocytosis has to be kept in mind, especially in the monsoon season, and dengue infection must be ruled out in suspected cases of MISC. Multisystem inflammatory syndrome requires a thorough investigation, not only to establish the diagnosis, but to exclude other important differentials and find out the extent of organ involvement. Complete blood count with differential count is necessary and may reveal lymphopenia and neutrophilia along with mild anemia and thrombocytopenia. Levels of inflammatory markers like ESR, CRP, procalcitonin, interleukin-6 are determined and are seen to be universally elevated. Cardiac markers like troponin, NT-proBNP are elevated in 68 to 100% of the cases and indicate myocardial involvement. Liver function tests often reveal mild derangement of liver enzymes and hypoalbuminemia. Renal function tests are done to look for renal involvement. Blood gas analysis is necessary for management of respiratory failure and shock. Coagulation defects are sometimes seen in MISC. Hence, coagulation studies including PT-INR, APTT and D-dimer levels needs to be done. ECG is also done, which may reveal STT changes and arrhythmia in case of myocarditis and electrolyte abnormalities, and low voltage waves may be seen in case of pericardial effusion. As discussed previously, sepsis is a close mimicker of MISC. Hence, in all suspected cases of MISC, efforts to find an infective cause must be made. These include blood cultures, urine analysis and urine culture, and workup for malaria and dengue. Additionally, other tests to rule out infectious etiologies such as scrub typhus, leptospirosis, disseminated viral infections may be done when clinically indicated. As you would recollect, the case definition of MISC requires a link with COVID-19 to be established. This is established by the presence of any of the following: a positive RT-PCR for SARS-CoV-2 in a nasopharyngeal or a lower respiratory tract sample, a positive antibody test which may either be IgM or IgG, a positive antigen test for SARS-CoV-2, or even a recent exposure to a confirmed case of COVID-19. As discussed previously, based on the published case series, around 50 to 90% cases of MISC have a positive antibody test. RT-PCR is negative in over 2/3 of the cases. Imaging studies are necessary in patients with MISC. The most important of these is an echocardiogram, which is recommended in all cases at presentation. Echo may reveal depressed LV function in 31 to 58% patients. Coronary artery abnormalities may also be seen in 8 to 48% cases and must be quantified using Z-scores to classify the dilatation. The Z-score calculators are easily available online. Pericardial effusion and valvular dysfunction may be noted on echo. In addition, a follow-up echo is also recommended at 7 to 14 days and 4 to 6 weeks of illness to look for residual cardiac abnormalities, including coronary artery abnormalities. Chest X-ray and CT scan may be done in cases with prominent respiratory symptoms and may reveal cardiomegaly, pleural and pericardial effusion, and ground glass opacities. Ultrasound abdomen is necessary for cases with severe gastrointestinal symptoms and may show ascites and inflammation of the bowel and mesentery. Having learnt about the features of MISC, we propose the following diagnostic algorithm. The first step is to determine if the child has all of the following features suggestive of MISC, such as fever, gastrointestinal symptoms, rash, conjunctivitis, oral mucosal changes, confusion, Palmer erythema, and an epidemiological association with COVID-19. If these symptoms are not present, the child is unlikely to have MISC, and further evaluation for other conditions is done as clinically indicated. If the child has these symptoms, we need to look for features of shock or cardiac failure. The presence of these features makes the possibility of MISC very likely, and these children need to undergo a thorough evaluation. This includes a basic battery of investigations, including RT-PCR for SARS-CoV-2, as well as more specialized tests, such as tests for cardiac function and levels of inflammatory markers like ferritin. If the child does not have these features of shock or cardiac failure, initially only the initial investigations needs to be done. If these investigations are suggestive of diagnosis of MISC as described previously, then the further more specialized tests would be done. In the initial investigations are not compatible with the diagnosis of MISC, then other conditions need to be looked for while monitoring carefully for evolution of new symptoms. To summarize, here is a pictorial representation of the features of MISC. Children have fever along with conjunctivitis, rash, swelling of palms and soles. They often have nausea, vomiting, abdominal pain and diarrhea with mildly elevated liver enzymes. Cardiac involvement is prominent with elevated cardiac biomarkers and echo abnormalities. There may be headache, meningismus and lethargy. Respiratory involvement in the form of hypoxemia and pulmonary infiltrates, although rare, may be seen. Blood tests reveal thrombocytopenia, neutrophilia and lymphopenia and elevate inflammatory markers. And importantly, there is a lab evidence of current or past SARS-CoV-2 infection or a history of exposure to COVID-19. Thank you.
Next.
Hello everyone, I am Dr. Juma. Shankar, Associate Professor in the Department of Pediatrics at the All India Institute of Medical Sciences. My topic for this series of webinar is management of multisystem inflammatory syndrome related to SARS-CoV-2 in children. The outline of this webinar would be, we will attempt to understand the spectrum of the multisystem inflammatory syndrome, review the investigations we can order and their relevance, the cardiovascular support and drug therapy which has been used in these cases. We will briefly review the data from India and abroad. We'll discuss an algorithm-based approach for tropical countries and finally, the challenges that are anticipated while managing these cases. I'll start with a case we managed in June 2020. A 6-year-old boy presented to the ED with an acute febrile illness with mucocutaneous rash and lymphadenopathy. On examination in the emergency department, he was found to be in shock and respiratory distress and managed accordingly. In addition, he had mucocutaneous involvement, bilateral cervical adenopathy, and edema of hands and feet. The differential diagnosis considered in the emergency and ICU at this point of time were Kawasaki disease with shock, toxic shock syndrome, and sepsis-associated multi-organ dysfunction syndrome. The index case fulfilled the case definition of Kawasaki disease. But was it Kawasaki disease or was it COVID-19 related MISC we needed to explore? The investigations done at the time of admission revealed elevated markers of inflammation such as ESR, CRP, PCT, and serum ferritin. We also got a COVID-19 test by RT-PCR which was reported to be negative. In view of the shock and suspected myocarditis, we performed an echocardiography which showed left ventricular dysfunction and borderline elevated troponin I. Tests for common infections such as dengue, scrub, typhoid were all negative. However, the total antibody test for SARS-CoV-2 was positive. As per the criteria laid down by the WHO and the CDC, a child who is presenting with fever, who has elevated markers of inflammation, with 2 or more organ involvement, and is positive for antigen or antibody for SARS-CoV-2 is suspected to have MISC. And the index case fulfilled the case definition laid down by both these organizations and was therefore diagnosed as a case of MISC. When we suspect MISC, apart from routine laboratory investigations, we need to send markers of hyperinflammation and perform echocardiography. Severe illness has been found to be associated with elevated markers of inflammation such as CRP, PCT, and interleukin-6 levels. As of today, the pathogenesis and spectrum of MISC is not clearly understood. A dysregulated innate immune response to the viral antigen results in cytokine storm, endothelial dysfunction, and the resulting multi-organ dysfunction that follows. The illness, therefore, may mimic one of these conditions. 1. It may mimic KD with or without shock. 2. There may be just hyperinflammation with myocarditis. And 3. There may be hyperinflammation and multi-organ dysfunction without myocarditis. In a recently published large case series of 570 children with multisystem inflammatory syndrome, the authors could classify these children into 3 classes. Class 1 comprised of 35% of the cases, 98% were serology positive and had more than 6 organ involvement. Class 2 comprised of 30% of the cases, and these children presented with acute COVID-like infection. They had ARDS, 84% were RT-PCR positive, and this group had the highest mortality. Class 3 comprised of patients presenting with KD or KD-like illness, and in more than 60%, the children were positive for SARS-CoV-2 antibodies. The cardiovascular support has to be tailored according to the clinical presentation that we just saw. Broadly, it comprises of antibiotics, IV immunoglobulins, and steroids. Steroids are considered as the first-line therapy in these cases due to their potent anti-inflammatory effect and may be given at a dose of 2 mg per kg orally till markers of inflammation subside, following which they are tapered over next 2 weeks. In severe cases with shock, we could try pulse methylprednisolone at a dose of 30 mg per kg per day for 5 days and tapered over 2 weeks. The concerns are there are no clinical trials and there are concerns with superadded bacterial infection with the use of these agents. IVIG is the other drug commonly used at a dose of 2 grams per kg over 24 hours as infusion. Again, the concerns are there are no clinical trials and there are cost and availability issues. Some of the other drugs that are considered are antibiotics to cover infections, antiplatelet drugs such as aspirin in KD-like illness, anticoagulants such as enoxaparin. These are considered in older children or in those with elevated D-dimers till 2 weeks after discharge. And now, let us see how cases in the US, UK and India have presented during the pandemic. In the UK series of 78 cases, 40% had coronary aneurysm and more than 70% required immunoglobulins and steroids. In the US series of 570 cases, 50% had myocarditis, and more than 80% received IVIG and steroids. From India, 2 case series have been reported from Chennai and Mumbai. The median age was more than 6 years, and more than 60% had myocarditis. Majority had received immunoglobulins and steroids, and there was only 1 death. This slide shows a suggested algorithmic approach to multisystem inflammatory syndrome. Accordingly, if a previously healthy child presents with a history of fever during the COVID-19 pandemic, first of all, we need to rule out the common causes, including dengue, scrub, leptospirosis, malaria, enteric fever, and other suspected bacterial infection. And also we need to screen for COVID as per guidelines. If there are features of KD, then do an echocardiography and send tests for markers of inflammation. If the markers of inflammation are elevated, then manage shock, respiratory distress, add antibiotics, and start immunoglobulins at 2 grams per kg over 12 to 24 hours. In this group of children, assess for improvement in fever and inflammatory markers. If there is no improvement or there is worsening, we may consider repeat immunoglobulins, IL-6 inhibitors, continuous steroids, aspirin if COVID-19 is positive for antigen, antibody, or there is history of close contact. If there is improvement, taper steroids over 2 weeks, continue aspirin for 6 to 8 weeks, and repeat an echocardiography at 2 and 6 weeks for coronary artery involvement. If there is no involvement, we may stop aspirin. If there are no features of KD and presentation is like sepsis, septic shock, TSS, multi-organ dysfunction, then we send appropriate investigation and start broad spectrum antibiotics. We perform echocardiography to rule out a myocardial dysfunction, and if there are features of myocardial dysfunction or injury, we may consider IVIG or steroids on a case-to-case basis. If there is no response in 48 hours and repeat COVID-19 test is positive, in this group of children, we may consider to repeat a dose of IVIG or give IL-6 inhibitors. So this is a suggested algorithm, and the treatment has to be individualized based on the case. Now, while managing these children, there are several challenges we may face from low middle income countries. The challenges we faced while managing this child and may face for similar cases from our country include clinical challenges such as overlap with other tropical infections, non-availability of serology test for SARS-CoV-2 antibodies, and to decide about what drugs to be administered and when. Others will be challenges with resource availability, such as echocardiography may not be available in all centers, laboratory testing for inflammatory markers may be unavailable, there may be issues with availability of PICU bed, ventilators, or IVIG. To summarize, MISC is an emerging spectrum of vasculitis and inflammation due to SARS-CoV-2 infection. The spectrum may vary from KD or KD-like illness to sepsis, MODS-like illness. And the presentation is similar to what we are observing in the West. The first line therapy is steroids and IVIG, and immunomodulatory therapy and antivirals are reserved for refractory cases and severe disease. An algorithm-based approach is suggested for a child with multisystem inflammatory syndrome. However, we have to individualize based on the presentation. While managing these patients, we may face unique challenges, and especially from resource-limited settings. Thank you.
Please continue to write your questions or comments on the chat box. And as we have learned that MISC is a newly emerging disease, and even it will be seen more commonly in our routine pediatric wards because their RT-PCR in majority, say more than 2/3, may be negative. So it is important to understand various clinical manifestations, and we should have a high index of suspicion for considering or making a diagnosis of MISC in coming few weeks or months. And they may be present, they may be in the COVID facility, but majority will be in the non-COVID pediatric ward. And please continue to write your questions. We'll try to answer them. And if you found it that it was very fast, you can visit, you can see or view these webinars on YouTube of AIMS Telemedicine. Okay, so now we'll take some questions. So one question is, what is role of low molecular weight heparin prophylaxis and therapeutic for a child with D-dimer of more than 1500 nanogram per milliliter, but no thrombosis? Dr. Nitin.
So again, it is for children who have severe disease and who have a D-dimer of more than 2500. We are giving low molecular weight heparin for such children. And if the D-dimer level is more than 1500 with severe disease and increasing trend, at that time also you can consider low molecular weight heparin. But we should be careful about any side effects, like it can increase the risk of bleeding if there is any active bleeding, or if there is a patient is having severe thrombocytopenia.
Okay, what is role of steroids in severe disease?
Steroids are probably till now, with the available evidence, steroids are the only therapy where some benefit, outcome benefit has been seen. So as of now, it is recommended that all children with severe disease, especially if they are having features of increased inflammation and are having severe lung involvement, should be started on steroids, either prednisolone or dexamethasone. And the duration should be titrated as per the clinical response.
Okay, any data on status of thymus in children with MISC? I am not aware about such data. Probably we are learning more and more, and they may come in future. Then there is another question related to a 12-year-old girl, fever with gastrointestinal symptoms, RT-PCR for COVID is positive, and day 3 CECT is suggestive of necrotizing pancreatitis. Echo is normal, D-dimer is more than 5000. How to approach? This child was previously healthy, means there was no some predisposing factor for pancreatitis. So as we are repeatedly saying that we are learning more and more about this coronavirus infection, COVID-19. It may be that all these clinical symptoms and features are related to COVID-19. Regarding D-dimer, if there is no contraindication, there is no bleeding, active bleeding, low molecular weight heparin, if it is more than 2500 D-dimer, or if it is a severe disease and rising D-dimer, we should be using it, but with monitoring for side effects. Same thing is whether we should be giving them steroids for this girl who is having acute pancreatitis. As steroids may cause a pancreatitis or may cause worsening of symptoms, so that needs to be given with caution. So if there is a pancreatitis and if a patient is having a severe disease, you may give it, but monitoring of the worsening of pancreatitis, but it would be with caution. Otherwise, if it is a severe disease with pulmonary disease, you will definitely go for a steroid. When to start anticoagulant in MISC?
So again, for MISC also the criteria remains the same. If there is features of increased D-dimer or there are features of thrombosis, then you will definitely start anticoagulants in form of low molecular weight heparin. And for if there is no such features, then you don't have to start a low molecular weight heparin.
Okay. Any other questions?
No.
Are there any? Okay, so if there are no more questions, thank you very much for participating in this specially prepared webinars for residents. If you are interested, you want to see them again, You can go to a AIMS telemedicine YouTube and you may be able to see. And as I told you, there are 16 webinars. Some of them we have not covered here, which includes how to prevent, what precautions are to be observed, what PPE should be used. All those things are there in our webinars. You can visit this AIMS telemedicine facility. Thank you very much. Even today's webinars will be available on AIMS telemedicine facility. Thank you very much. Thanks.